feel a bit like I've got the graveyard slot. Most of what I'm going to say has been covered already. So, Mike asked me to talk about Pilons, and then I thought about it, and to be honest, as we've already heard from Tim and so on, the difference between Pilon and ankle fracture in this age group is indistinguishable, to be honest. So, in my view, they're much the same thing. So, what are we dealing with? We've talked about this before, and probably these first few slides are the most important that I'm going to give. We're dealing with an increasingly elderly population. I'm not saying we should put nails up everybody, of course I'm not. But these people, they're osteoporotic, they've got poor soft tissues, which people have talked about already. They are out and about more, and they are more likely to fall over as a result. And the group we're talking about here is the group that cannot or will not weight bear. And all of that has to be taken into account when you're doing these. They've got multiple comorbidities. They've got unstable fraction. I said the Pilon and the ankle I'm putting together because I don't think you can separate them from these. And the other one that I've just put in there for completeness sake is the very distal tibial stress fracture, which you could consider for these as well. But you've got local issues. You've got problems with the soft tissues. It may be open, or they often are with the patients coming to us. They may have ulcers, varicose eczema, thin skin, neurological compromise, and they've certainly got thin bone.
You can see it.
Oh, you can see it. I can see it up there. Have I got a thing to?
Oh, so could we ask you just come to the mic so we can we can capture this on the recording and
Right. So we've been through all this, and those are the key things: mental state and can they walk? And okay, we've all seen. Where's Tim Chesser? There you are, Tim. This is one that you've used before. Of course, not everybody's that good, and you've got to bear that in mind. So what are we trying to do? We've heard this before. It's the same thing. If whatever we're going to do to them, we want to get the patient moving as quickly as possible. We've got to get the soft tissues healed, and we've got to get the fractures stable and healed. So that's what we're up to, and we've been over the various options with the previous speakers. So I'm not going to dwell on that. But this is the point. There's no one thing that we can do that's going to solve this problem. We've got to think of the whole lot. It's conservative. You know, we've got problems there. Bob's did a very good thing on the consent side of things. But the group we're talking about, or I'm talking about specifically with nailing, are people that you're not going to be able to hold, i.e. the fractures are unstable. Okay, so and we've tried this and run into all sorts of problems. So if the fracture stable can be reduced and you can weight bear them on it, then fine. We'll go down that route. But the ones we're talking about, you can't do that. External fixators, again, we use them, ring fixators. The group we're talking about, you put a fixator on, you end up with a compound wound on the other side because they knock hell out of the other leg. There's all sorts of problems with these. They're not straightforward at all. And although you can use these widely spaced bars and so on, the general ones are not necessarily particularly plastics friendly, and that's something we have to think about as well. Open reduction, internal fixation, yes, if you've got good bone, good patient, fair enough. But this is a problem that we've seen so many times when we've tried to fix these fractures. And what Tim was talking about earlier is this business where you get this impaction of particularly the lateral plafond. And if you get that fracture with a bimalleolar pattern, that is unstable, that is not going to stay there. You're going to have to do something pretty solid to get that patient moving. And we've all been caught out, and you know what you don't want to end up is there. Locking plates, again, we use these. The problem I've got with them, particularly on the fibula in the elderly and at the back with the posterior malleolar fractures, they're bulky. And they're stiffer, and the non-union rate with them, as a result, has been reported as being higher. So you've got to think about this in the elderly group. Augmented fixation, okay. Better than standard fixation, maybe, but you still need to make big holes. You've still got the potential problem with wound healing. So nails, there's nothing new. The first reports of using Steinman pins and so on were in the early 60s. The first report I could find in the literature relating to lock nails was by Lemon and Co. in 2005, and then we published on it in 2008. So there's nothing new. It's been around a long time. So the pros, in my view, it's quick. These can be done in 35, 40 minutes by most surgeons. They're percutaneous, so you've got low infection rates. They are mechanically strong. It allows you to get the patient going straight away. They're plastics friendly, which is of course very important, and it allows you to keep an eye on the skin. The cons, obviously you've lost joint movement. You've got joint surface damage, though interestingly, the few that we have ended up taking out, they seem to move perfectly well afterwards. but not that you need to do that in many cases. So the series that we published, they're small numbers, we only had 13. All the fractures united, we didn't have any infection, but the key point is 50% of the patients were out of hospital within 2 weeks. And the bottom line there, again, is also very important. What you've got to remember about these patients, and Ian mentioned it earlier, is 50% of them were dead within 2 years anyway. So it's important. So we've done many, many more now since we've had major trauma centre status. We're certainly, well, you were telling me, Andy, I think we're up over 100 now with these. And we've only had 2 that I know of that have been removed for infection. And we took 1 out late for stiffness in this group. But this is the sort of thing that we're dealing with. If you try and fix that, it's going to fall apart. So what you've got to try and do is avoid getting into trouble in the first place. And I would argue that a nail in this group is a very reasonable option. Points I would make, I haven't got the time to go into this in detail, but if you are going to put these nails in, put them in properly. Get your entry points right. I mean, this was actually the picture on the left here, which actually came out of a published paper, and I would argue whoever put that in didn't really know what they were doing. You've got to get your entry points right, you've got to get the talus underneath the tibia and the calc in line with that, and get the nail entry points in the right place, because if you don't, the foot's going to go down into equinus, and how that person mobilised afterwards, I don't know. We much prefer a curved nail. I mean, I know that's a Bristol thing probably, but if you think about it, the angle you're putting these things in, if you put a straight nail in, you're either going to put your entry point in the wrong place, or you're going to shift the talus across normally medially, and the medial malleolus will fall off. So I would argue a bent nail gets you reduction in a more anatomical position. The newer nails have got this posterior to anterior lock along the length of the calcaneum, and you can put a locking screw in the end there that impinges on that and gives you a much more stable construct. So the current nail we're using is this one. It was interesting, Charlotte, I saw you were getting screws backing out more proximally. That's not been particularly my experience, but the ones that do tend to loosen are these ones in the talus and the calcaneum going side to side. And it's something we've mentioned to the companies that maybe you do need something like one of these nylock systems where you put a screw in, particularly for the side to side ones, to stop it moving out. With normal bone, when doing the formal fusions, we decided that the shorter nail was probably better. There's some evidence in the literature, though this paper wasn't a particularly good one. If you're worried about the bone in general, of course you can put a longer nail up. But, there's very little evidence for that. So I'm not suggesting, of course, that you should do this for everybody, as I said earlier, but in a selected group, and the key is with the unstable fractures, poor skin, poor bone, and poor protoplasm, and I mean that the patients that aren't able to cooperate and do what you want them to do. So it's a reasonable option to think about the nail in that scenario, but there is no panacea, and of course you have to treat the beast. They're extremely challenging injuries, they're extremely challenging patients, but what we do need to do is get the patients mobile as quickly as possible while protecting the soft tissue, stabilising the fracture and the bone. So the nail, I would argue, provides bony stability. It allows the fracture to heal. It's a quick operation. It's minimal soft tissue damage. Supports and allows access to the soft tissue, so you don't need a cast, so it keeps your plastic surgeons happy. And of course, you can get the patients going straight away. But last thing, remember, this is the NOF population. 50% of them are likely to have died within 2 years. Charlotte said this before, and I'm saying it again, you get one shot at getting it right. What they do not need is numerous operations, and what they do need is to get going properly and quickly.